I put it all in the same,
Yeah.
really. It should be good.
Okay. Good morning and welcome to the House Health and Government Operations Subcommittee on Insurance and Pharmaceuticals. We really appreciate your flexibility and your conscientiousness about watching the time changes of subcommittees at this time. For the next 3 weeks, we will have to be very agile as schedules change. The floor sessions get longer, the bill hearings get longer, and we have a lot of bills to cover before crossover, which is the middle of March. So thank you in advance. Thank you for being here this morning, and thank you in advance for staying on top of things as we move forward in this session. We have 4 bills today. To my knowledge, I think most of them have been worked out, and that folks are have come together in agreement, but we are open to discussion. We're going to start this morning with House Bill 11, Health Insurance Access to Non-Participating Providers, Referrals, Additional Assistance, and Coverage. This is Delegate Sample Hughes' bill. Lisa, will you tell us what it does? And I think we have to do an amendment as well. Is that right?
Yes, it
Okay.
is.
Mm-hmm.
So this bill alters existing requirements on health insurance carriers regarding referral procedures for non-participating specialists and non-physician specialists. The bill also repeals the termination date for chapters 271 and 272 of 2022, which required specified carriers to cover mental health or substance use disorder services provided by a non-participating provider at no greater cost to the member than if the services were provided by a participating provider under specified circumstances. The amendments that were distributed clarify the circumstances under which a carrier is required to make a referral to a specialist or non-physician specialist for a member seeking mental health or substance use disorder care under certain circumstances, and provides that if a carrier approves a certain request for a referral, the carrier may not require utilization review other than what would be required if the covered benefit were provided by a provider on the carrier's provider panel.
Take a breath. Thank you. Delegate Sample Hughes, are you in here yet?
Yes,
Great.
yes.
Would you like to speak to your
Thank you.
bill?
Sure. Good morning, Delegate.
Oops, Delegate, you
Sorry,
we lost
I'm
you.
having technical difficulties this morning.
Oh,
Okay, so I wanted to make you aware, as well as the subcommittee, that on since the bill hearing, I have met with the insurance carrier, and we've had actually 2 meetings and been able to iron out some of the details as it relates to the Maryland Insurance Administration's suggestions. And since then, and the carriers are on here as well, but they can speak to the fact that we are all in agreement with what we have in this language, and it takes care of some specific concerns as it related to the treatment, the verbiage on how or what that really means. And so to that end, I think we're in a very good posture. But on this call, Mike Patty is on, as well as Kimberly Robinson, if you have specific questions.
okay. Well, thank you. Thank you very much, Delegate, for your work on this and for working to get us to a good point. Are there any questions from the committee on the bill, or do I have a motion on the amendments?
I'll move the amendment.
Okay, I've got a motion and a second on the amendment. Any discussion or questions on the amendment? Seeing none, all those in favor of the amendment, please say aye or raise your hands. Will there be any opposition to the amendments? Seeing none, the amendments pass unanimously. Is there a motion on the bill as amended?
Move the bill as amended.
Okay.
Second.
Okay, I've got a motion and a second on the bill as amended. Are there any questions, any discussions on the bill as amended? Seeing no virtual hands, we'll put it to a vote. Those in favor of the bill as amended, please say aye and raise your hands. Will there be any discussion or any opposition to the bill as amended? raise your virtual hand, please. Seeing none, the bill as amended passes unanimously. Thank you very much, Delegate Sample Hughes and committee, for help with that bill.
Thank you,
Um,
delegates.
Thank you. We're going to go to House Bill 848, Health Insurance, Adverse Decisions, Reporting and Examinations. This is Chair Pena Melnick's bill. I'm not expecting the chair, although Brigida, if you can tell me if she is here.
No, I don't see her.
Okay. Then Lisa, tell us what the bill does.
The bill expands the required contents of the quarterly appeals and grievances report each carrier must submit to the insurance commissioner. If the number of adverse decisions issued by a carrier for a type of service is grown by 10% or more in the immediately preceding calendar year or 25% or more in the immediately preceding 3 years, the carrier must include a description of any changes in medical management contributing to the rise in adverse decisions for the type of service and any other known reason for the increase. The bill authorizes the commissioner to use this information provided in the quarterly reports as a basis for an examination of the carrier. The amendments that have been distributed require denial and grievance notices to include certain information at the top of the notice in prominent and bold print, require private review agents to make available a phone number and email address dedicated to utilization review that will be responded to within 2 business days, require specified information to be reported by zip code, and require carriers to report a description of efforts and actions taken to determine certain increases in adverse decisions.
Okay, any questions, discussions on the amendments? Seeing none, can I have a motion on the amendments?
Move the amendment.
Okay, I've got, motion and second on the amendments. Any discussion on the amendments? Seeing none, those in favor of the amendments, please say aye or raise your hands or both. Anyone opposed to the amendments? Seeing none, the amendments pass unanimously. Can I have a motion on the
Move the
bill
bill
as
as
amended?
amended.
Second.
Okay, moving the bill is amended. Any discussion on the bill as amended? Seeing no hands, those in favor say aye or raise your hands. Any opposition to the bill as amended? Seeing none, that bill passes unanimously. Okay, let's go to House Bill 995 because it's in the same sort of arena of issues. And Lisa, want to tell us what 995 does?
This bill establishes a work group to study the rise in adverse decisions in the state healthcare system. The Health Services Cost Review Commission and the Maryland Insurance Administration jointly must provide staff to the work group. By December 1st, 2025, the work group must report its findings and recommendations to specified committees of the General Assembly. There is an amendment that adds some additional members, alters the staffing requirement and appointment provisions.
Okay, any questions or discussion on the amendments or the bill? Seeing none, can I have a motion
Move
on
the
the amendment?
amendment.
Second.
Okay, I've got a motion and a second on the amendment. Those, any discussion? Seeing none, those in favor of the amendment, please raise your hand or say aye.
Aye.
Delegate Morgan, are you voting or you have a question?
I was just asking a question about the study. I mean, I want to make sure I understand, what are we studying here? That it's the total cost of care model, right?
I'm not sure that it would be a part of the total cost of care model, but it is really trying to determine why we've seen the recent increases in the adverse decisions and what, if there's something that needs to be done to remedy them. So it's sort of a companion bill to the data gathering that 848 is going to be doing.
Okay. All right. Thank you.
Any other questions? Seeing none, those in favor of the amendments, please say aye. Raise your hand. I think we did that already. Any opposition to the amendments? Seeing none, those in favor of the bill as amended, please say aye. Raise your hand. Oh, wait, do I have a
Well, we
motion?
haven't moved it yet.
Move the
There
bill
we
as
go.
amended.
I was going too
Second.
fast for me. Okay, I've got a bill as amended. Second, discussion on the bill. Seeing none, those in favor of the bill as amended, please raise your hand or say aye. Any opposition? Okay, excellent. The bill passes unanimously. Thank you all. Last bill, we can be proud of ourselves this morning, is House Bill 869. This is Preserve Telehealth Access Act of 2025. This is Chair Pena Melnick's bill. Lisa, what does the bill do?
This bill makes permanent the provisions of law that specify that telehealth includes specified audio-only telephone conversations between a healthcare provider and a patient, and reimbursement for a telehealth service must be made on the same basis and at the same rate as if the service were delivered in person. This bill applies to both Medicaid and the commercial health insurance carriers. There are two separate amendments that have been distributed. The first amendment is from the League and requires the Healthcare Commission to conduct a study every 2 years on any new developments or advances in telehealth. And then the second amendment is from LifeBridge and ATA Action, and it removes a prohibition on prescribing Schedule II substances through telehealth.
Okay, let's take the amendments separately. And so the first one that Lisa spoke to was the one that is intended to make the process be current. So I see some questions. Delegate Kaiser, or some discussion?
Thank you, Madam Chair. My questions aren't on the amendments, but on the overall bill, so I can wait.
Okay. Jake, do you have a discussion or question on the amendment?
Yes, thank you, Madam Chair. Respectfully, we do think that this issue has been adequately studied, but if the committee does deem it necessary to continue studying this issue, we'd ask that we do it every 4 years to align with the Senate version of the bill. Thank you.
Okay, thank you. Delegate Kaiser, your hand is still up. You wanna wait though?
I'm just waiting for I'm just waiting for later so I don't get forgotten.
Okay, got it.
Yeah.
Matt Celentano? Matt? Okay, Matt.
Madam
is-
Chair, Madam
there he
Chair,
is.
I
Okay.
am so sorry. I
That's
was
okay.
utilizing the healthcare system with a child, so I am unfortunately in the car. I would request that the 2-year amendment stays. We have plenty of time, and I'm sure we can change it and fix and make sure that the bill is aligned, as opposed to the 4-year. I think it's a great addition, considering the world is moving very quickly, and I have no idea how to handicap where we're going to be in the next 12 months, let alone 2, 3, 4, 5 years. And because of the ongoing work that the MHCC is doing on telehealth already, I don't think it would be too much of a stretch to ask them to keep the committees updated on what's happening and all the changes that are happening in the marketplace and in consumer care. And it just seems like an appropriate catch up as we move forward with this emerging and evolving modality and technology.
Okay, thank you. Robin Elliott.
Good morning, Robin Elliott on behalf of a lot of different organizations, FQHC, school-based health centers, PAs, and we would also ask for the bill to align with the 4-year provision. We are mindful of how much work the Healthcare Commission is doing, and think that certainly if something comes up between now and 4 years from now that the committee wants the Healthcare Commission to look at, they can certainly ask. So we're just concerned in the long run, if we think 10, 20 years out, this idea of a study every 2 years might not be as productive. So thank you very much.
Okay, Delegate Johnson, thank you.
Thank you, Madam Chair. I've listened to both arguments about the timeline and, I agree with both. However, I think we would want to know on a 2-year basis, at least for the first report. So is it possible to be a compromise to get the first report in 2 years and then 4 years after that if there are no issues?
That is possible. Lisa, could we amend it to say that with a report in 2 years from the start date and then 4 years in subsequent years?
I am pulling up the amendment really quickly. I think it says that the first one is due on December 1st, 2026.
Okay.
So that would be,
Okay,
it's actually probably even a little bit less than
Less
2
than
years.
2 years.
okay,
Right.
yeah. Okay, just so we get a snapshot after we implement it, see what's going on, how it's working. Yeah, I'd be good with that.
It doesn't, does the amendment, and I don't have it in front of me, I'm sorry. The amendment say every 2 years? It does say every
Yes.
2 years after that.
Yes. So that is, we can change that to 4. That's up to the committee.
So the first report on 2026 and then every 4 years after that?
Yeah, that would work as long as we kind of get an update to see how it's working right off the bat.
Yeah.
And if we're satisfied, yeah, go to the 4-year.
How do other members of the committee feel about that? If we amended the amendment to say the first report is December 26th, but after that, it's every 4 years.
I like it.
I'm seeing a lot of smiles. So can I have a motion to amend the amendment to say the first report will be due December 2026 and every 4 years after that?
So moved.
Second.
Okay, and a motion and second. Any more discussion on that amendment to the amendment? Seeing none, those in favor of the amendment to the amendment, please say aye or raise your hands. Any opposition to the amendment to the amendment? I'm assuming that Delegate Kaiser and Delegate Johnson are okay with it, since they moved and seconded. And so the amendment passes unanimously. So that takes care of the first amendment. The second amendment is coming to us from LifeBridge, and I am going to let Jen Witten speak to this amendment.
Great. Thank you, Madam Chair, and appreciate your time, committee, this morning for this amendment. We noted in our testimony, along with ATA and I believe Johns Hopkins and the University of Maryland, and we have representatives here today on this, but this amendment simply pulls Maryland current statute into alignment with where the federal guidance is. When we passed the first Comprehensive Preserved Telehealth Act, I believe in 2021, the DEA had some restrictions on how certain prescribing modalities would be used. Those guidelines have been adjusted to allow for the flexibilities. And so this simply just gets us in alignment with federal guidance and allows us to provide care to some of our, I would say, most vulnerable patients, suffering from cancer, sickle cell, and others. And again, we have providers here who can speak more to how they use these modalities, but that's the intent of the amendment today.
Okay, thank you. Questions, discussion on the amendment? Delegate Johnson, is your hand raised for that?
Sorry, Madam Chair, that's a holdover.
That's okay. Ernest Williams.
Good morning. My name is Ernest Williams. Oops, I'm frozen. I think I'm back.
There you go.
From the Health Education Advocacy Unit for the OAG. I think when we reviewed this amendment, we were I guess we didn't weigh in on this bill because it was simply removing the sunset, and then we saw this amendment, and I feel like it changes the essence of the bill. I mean, I'm a nurse as well, so I completely understand the need to provide opioids to consumers who may be unable to get to their appointments. But I think that it changes the essence of the bill without having a discussion or conversation about the consumer protections while we're dealing with, opioid overuse and Medicaid fraud and the pill mills that, the state is facing and the investigations and how long it takes to actually find, and prosecute and actually the impact that it has in the community. And so I think that's our concern, is that this amendment, removes those protections without any type of barriers where there's some specifics that are included. I mean, just being a telehealth provider doesn't mean you are within the state, right? Anyone can get a license and become a telehealth provider, and that just puts more people at risk of fraud and potential opioid misuse. So that's just some of our concerns with the amendment at this time.
Jen, can you speak to the experiences with the DEA guidance around this in other, I'm assuming it's been happening elsewhere.
Absolutely, Madam Chair, and I'm happy to provide some follow-up information. And again, we also have Dr. Helen Hughes here from Hopkins, and I think Dr. Rojo from University of Maryland, and Christy Fogley. And just to assure, so the DEA guidance allows for certain modalities and certain circumstances, especially in the context of pain management, to provide prescribing via telehealth modalities. And these are for, certain classification of patients. And just to assure the committee, because I know there was a lot of discussion, I think the providers can speak to it. The providers still have to follow all of their licensure standards, clinical practice, all of those standards apply. So should a provider be outside of that scope, they would be held to the same discipline as they would in person. So just making sure that there's still all of those protections. They would also still have to follow all of the state guidance on how we use a PDMP and how we report when we're prescribing a certain classification of drugs. So none of those provisions would go away. That oversight would still be required per state Maryland law. So, Madam Chair, maybe perhaps the providers who are here today can speak a little bit more about their practice, if that should help the committee.
That's great. And I saw Dr. Roggio first.
Thank you. Yeah, so I'll just jump off of LifeBridge here and just say, this amendment I think is really important, especially for those people like cancer patients or post-trauma patients, hospice patients, a lot of whom that we see at University of Maryland. And to go off the previous point as well about the standards and guidelines that are currently in place. Yes, every time a provider has to write a prescription, he has to check the PDMP, make sure that the patient is not getting extra pills somewhere else, or make sure that they're aware of what the patient has already been given in the past in order to prescribe a new opiate medication. I think that Maryland has some very good and safeguards when it comes to opioid prescribing already. This is just a way for us to get to those patients who can't come to us, because there are so many of those cancer type patients who come out and are just unable to get to their appointments on a regular basis because of their chronic pain or other issues with chemotherapy, et cetera, that they can't deal with and go to them.
Thank you. I'm going to go with Dr. Hughes and then to Delegate Johnson.
Thanks. I totally agree with all the patient-facing needs, but I just wanted to provide some clarity around the federal guidance and the confusion. So, there were federal Ryan Haight and other restrictions in place. Those have been waived since COVID started and have been continued to be waived. And most states are silent on this issue. So having this pre-COVID statute makes us kind of more restrictive than other states. The federal government and DEA have proposed 2 proposals to have a special registration for telehealth and an even more special registration for Schedule 2 telehealth prescribing. The first one had 38,000 comments. So there is no current federal solution to a special registration for controlled substances, but that's the federal plan. So basically, we are currently more specific and restrictive than our neighbor states. And when there's a federal solution, we will still be more restrictive.
Okay. Thank you, Doctor. Delegate Johnson.
Thank you, Madam Chair. So when the prescribers from out of state prescribe, is all this all this information still reported to CRISP so it can be tracked?
That's my understanding that it would, but I am gonna look to Lisa to see if you have information on that.
That's my understanding as well. I don't know if any of the practitioners, I think they might practically, no.
Yeah, it's all electronically prescribed now. So you would need a DEA, a Maryland CDS, and it would be going to a Maryland pharmacy for a Maryland patient. So all of that should still be in CRISP, but I'm happy to follow up on that.
If you would, I think that would be something that is important for us to know.
Okay, so I'm gonna take Delegate Kipke.
Thank you, Madam Chairman. I forgot the name of I forgot what we call it, but there is a Maryland version of the DEA that we authorized through legislation to basically review and audit pharmacy as it relates to CDS. So I think there are safeguards in place to root out any bad actors, and they have done it. They have gone after them. So I just like to say I support the amendment. Thank you.
Okay, thank you. Delegate Johnson, are you comfortable with us moving forward knowing what Delegate Kipke just told us?
Yes, Madam Chair, that's okay.
Okay, great. Then do I have did I have a motion on this second amendment? I think I did before we started discussion. So on the second amendment, those in favor, please say aye.
Aye.
Raise your hands. Any opposition to the second amendment? Seeing none, the amendment passes unanimously. Can I have a motion on the bill as amended?
Move the bill.
I've got a motion. Do I have a second?
Second.
Any further discussion on the oh, Delegate Kaiser. Thank you.
I was hitting my chest because I was coughing, not to like say, please call me. Thank you, Madam Chair. I just had an overall question about in regards to the bill, all the references to audio only and the coverage. And I asked a question at the hearing, but I still didn't quite get the clarification. Why video is excluded, or is it not excluded? What, there's all that reference to audio only. So could you explain?
Video is not excluded. It's
Okay.
just that audio is explicitly included, because that was the area that we had the most concern about when we did the original bill during COVID. That an audio only session would be considered the same as a video or in person. Does that make sense?
Okay. Not fully, but I'll trust you. Let me ask my second unrelated question. I mean, during the pandemic, when we finally moved forward and figured out telehealth was good and great and we were helping people, how does this bill impact cross state lines, Maryland people being in other states or people in other states who are living in Maryland temporarily? I just missed that feature.
The federal laws on that have gone back and forth, and I'm not sure where they are now. Jen, do you have any information on that? I mean, there was a period of time where across state lines was not permitted, but I thought I had heard recently that had changed.
So as far as I know, and I think maybe Dr. Hughes can also speak to this, but it would still be the case that you would need to have a Maryland license, is my understanding. In some cases, we have reciprocity with bordering states, but there was a small exception, of course, during the pandemic. There was a desire to expand that, but just lots of questions around how that would actually work. So currently, you still have to provide. You have to be a licensed provider in the state to provide care to Maryland patients. I'm seeing Dr. Hughes agree with that. So that's my understanding.
Okay.
There's a brief window, but
thank you for that clarification. I'm just still concerned that, the movement across the country, that we have students and other people who are long-term temporarily in other places are excluded from seeing their regular doctor. But I have a bill related to that, and I'm just trying to distinguish a little bit. So thank you for the clarification.
Thank you. Thank you for your questions. Delegate Johnson.
Thank you, Madam Chair. We're moving this bill forward, but I would still like to have that information on out-of-state prescribers, if that's okay.
You got it.
On other bills. Thank
We
you.
will make sure you have it. Dr. Savage. Dr. Savage?
Sorry about that.
Oh, there he is. Okay.
In answer to the previous question, I think our practice depends upon the compact between the states. In our particular, I'm a psychologist. In our particular compact, we are required to practice by the laws that the state into which we are providing service at this point requires of us. So if audio only was not allowed in, say, West Virginia, then we would not be able to do audio only appointments into West Virginia. We'd only be able to do whatever they've authorized, which probably would be the visual.
Okay. Ernest Williams?
Yes. So since the bill is moving forward, I think the only thing that we would want to add is if the MHCC's timeframe was updated or at least reviewed, because I think that's what I think the delegate, I can't see it. Maybe it was Kipke had mentioned that there's, people who review the pharmacies and things of that nature, but we may need to increase the time because it takes so long for fraud or issues to be found and then investigated and then prosecuted. And so if we update the time frame or at least review it, we just want to make sure that if there are bad actors, that we're able to find them a lot more quickly than the current time frame that we have.
Thank you for that. I suspect we can deal with that in regulations around prescribing. So, and look at what the current practice is. Delegate Shalega.
Thank you. I'm still not clear about whether a Maryland patient who has a Maryland, let's say a primary care provider in Maryland, the patient is in Florida, can they provide telehealth care to them or not?
My understanding is if it's a member of the compact, if the state is a member of the compact that Maryland is a member of, then that works, that meets it. Or if I have to get clarity around this because I am not sure.
Yeah, I would entertain that. I don't know if this is the bill to fix it. My opinion, that should be fine. If your primary care physician is in Maryland and you travel to Disney, and you need you're sick and your physician is able to do a televisit with you, why not? Why not make that why make them go find an urgent care or, that type of thing? I think that makes sense. If it is your primary care, if it's your regular doctor, they should be allowed, this is technology. So I'd like to know the answer to that. And I don't, whether this would be the place to ensure patients can continue being cared for by their physician.
Delegate, I would offer that all doctors in Maryland feel exactly the same way you do. And I think most patients do as well. It's a question of federal preemption and whether or not the federal government is allowing it. So that is the question. Delegate Roggio?
Thank you. I'm not a delegate, but I appreciate it.
Oops, doctor.
So what I was going to just add to that, so the ability, I agree 100%. Every doctor in Maryland would want to continue to see their patients regardless of what other state that they go to. It is entirely dependent on what the state that the patient is physically in at the time allows. So I cannot practice medicine in a state where I am not licensed or does not have an allowance for me to practice across state lines via telehealth. It's all dependent on what that state has in their own regulations regarding telehealth in general. In Florida specifically, for example, they require any provider to practice who wants to practice telehealth to get a telehealth, it's like a telehealth license. It's cheap, it's easy, but it is still a process that you have to go through before you can start seeing your patients if they are physically in another state. That's state by state dependent. So it's not even, there's nothing I think at the federal level barring anyone from doing it, but at the state level, there are variations between all the different areas.
Thank you. Thank you. Dr. Hughes?
The MHCC does have a study on this, and we have a lot of federal level advocacy on this issue. So I'm literally happy to talk to anyone at any time about this. And we're trying to work to see if we can have federal solutions because the state by state approach is very challenging.
And thank you. And in the meantime, this bill doesn't, it can't move us forward on that, but we could make sure that within Maryland, everyone is covered. Delegate Bandari.
Yeah, thank you, Madam Chair. This is wonderful bill. Just a few questions for the courier. This bill does not mandate in-person visit before prescribing high-risk substances, right? Some states require mandatory in-person visit for the first prescription of controlled substances. I believe this any of these amendment does not explicitly include that. Is that correct?
The amendment actually removes that requirement so that you wouldn't have that requirement. The amendment we just passed. The doctor could prescribe an opioid for pain management through telehealth.
Okay, so how does the committee think about the safeguard to prevent potential misuse? I'm fine, just I'm kind of concerned when I was looking other state bill.
Right, that's the conversation we were having about the requirements around for any prescription, any opioid prescription must be reported to our pharmaceutical management program, and so Chris keeps track of those, and any doctor who's in Maryland who's prescribing it, it will pop up that this person is getting opioids from someplace else. So those safeguards are there, and as Delegate Kipke told us, within Maryland we have an agency that is also looking at those issues. So we felt like that's why the amendment just passed, because people felt like the guardrails were sufficient.
Okay, thank you.
Delegate Johnson.
Thank you, Madam Chair. On the discussion about across state lines, isn't that why we've had to form compacts? So requirements and regulations are the same in each state, and the federal government doesn't allow just open-ended state-to-state treatment?
That's part of it facilitates, the compacts facilitate it for sure. I'm not sure it was the driving force behind telehealth, but it definitely facilitates it.
I mean, I just thought that may be an obstacle. Delegate Szeliga brought up a good point about patients being able to get to their doctors, but I think that's why we've had to form compacts, because the states have to make sure that regulations and requirements are the same before they let someone practice in another state or from out of state.
Right. And the other reason is because, of shortages. So you can have access to doctors who may not live in Maryland. So, yeah.
Thank you, Madam Chair.
Okay. Seeing no other hands, we have the motion on the floor for the bill as amended. Those in favor, please say aye. Raise your hands. Anyone opposed to the bill as amended, please raise your virtual hand. Seeing no one, the bill passes unanimously as amended. That completes our work before us today. Thank you all very, very much for your discussions, your participation, and hopefully we'll be able to meet on Tuesday at 11 o'clock. There are a number of insurance bills that are coming up for hearing today, so we'll be taking a look at them. Thank you all very much, and have a great rest of the day.